Hello, I am Martin Lederman, co-founder of the organization One World, One Vision. Over a decade ago, my associate and I, while on a surgical mission to Belize, founded One World, One Vision in order to train local ophthalmologists and, by doing this, extend our reach. We were successful, and since then, our organization has gone to multiple countries and have demonstrated the success of our ideas. We added anesthesiologists and pediatric intensivists to the mission in order to train local physicians and make the surgical experience of our patients safer. Since then, we have realized that the paradigm of one patient, one student, and one surgeon, while successful, could not begin to address the need. There are tens of millions of children and adults with strabismus and amblyopia. We decided, therefore, to support and to promote a video course in strabismus and amblyopia and approached Dr. Burton Kushner to develop a curriculum and to recruit worldwide experts to give lectures. We stipulated that the course should be translated into multiple languages and to be distributed without cost around the world to eye surgeons. We are particularly grateful to our former patients and friends who have given the financial support to make our dream a reality. We are delighted that Dr. Kushner has accepted the challenge, and we hope you find the lectures both stimulating and educational, and that you share them with your colleagues and your students. And so, without further ado, I give you Dr. Burton Kushner.
Welcome, viewers, to this lecture on vertical strabismus as part of the One World, One Vision comprehensive course on strabismus. I'm Burton Kushner, and I'm going to be presenting today's lecture. If you are new to this lecture series, I'm glad you joined us. If you're a repeat viewer, welcome back. Vertical strabismus is certainly interesting and challenging. I recall once talking to a comprehensive ophthalmologist many years ago who said that if eyes were misaligned inward or outward, he could tackle them. But if there was a vertical problem, he would refer it. Certainly something that we want to learn more about. Today, I'm going to talk about vertical strabismus both with respect to diagnosis and treatment. I'm going to start with diagnosis. I'm going to begin with this video, which really got me interested in this subject many years ago. This goes back to the 1970s. I was operating, and I hear that this very well-known professor at the university was in the emergency room. He had been in a motor vehicle accident and had double vision. I was scrubbed, so I sent my resident down to at least take a look and give me a preview. He came back and said the patient had a left superior oblique palsy. Let's take a look. This man developed double vision after a motor vehicle accident. He has a left hypertropia, which increases in right gaze. It also increases on left head tilt, meeting the three-step criteria for a left superior oblique palsy. In fact, he has an orbital floor fracture in the right eye and fixes with the right eye because of mild amblyopia in his left eye. So this is, if you will, an index patient for me who got me interested in the subject of errors in the three-step test. We all know about the three-step test, rely on it, and I would submit often rely on it to a greater degree than we should. You see, the three-step test is predicated on the assumption that there is a palsy of one vertical muscle. And of course, there are a lot of other causes of vertical strabismus. This is the first example, a restriction of a different muscle, in this case, the contralateral inferior rectus muscle. Multiple muscle involvement. Let's take a look. These are the measurements of what appears to be a classic right superior oblique palsy. A right hyper, it increases on left gaze and on right head tilt. But if we add measurements not called for by the three-step test, measurements in the oblique fields, and also measure torsion, we see that up and right, up and left on your screen, there's a left hypertropia. And of course, if a patient with a right hyper in most fields of gaze has a left hypertropia in any field of gaze or on head tilt, we must be dealing with something other than a palsy of one muscle. This patient has a bilateral asymmetric superior oblique palsy, and the added measurements of torsion, 17 degrees total in this case, indicate that we're dealing with something more than just a unilateral superior oblique palsy. The three-step test assumes that there is one muscle involved. Prior surgery. Well, if multiple muscle involvement can cause errors in the three-step test, prior surgery can also, because now we're dealing with iatrogenically weakened other muscles or perhaps tightened other muscles, and that's also going to give us an erroneous diagnosis. Prior vertical surgery, the three-step test is not really useful at all. DVD. And I want to say parenthetically that part of the series is going to have a completely separate lecture on DVD, which will in depth cover the management of that condition. But I'm going to talk a little bit about some diagnostic criteria. Classically, DVD behaves opposite of a superior oblique palsy. So in other words, here is a patient that has a left hyper due to DVD. It increases on right gaze, as you can see in the upper left-hand photo, but unlike a superior oblique palsy, it classically increases on contralateral tilt rather than ipsilateral tilt. We're going to talk a little more about this a little later in the lecture. DVD on head tilt. This is the classic pattern which I just described and outlined for you. This woman has DVD greater in her left eye than her right. She shows the classic response to head tilt. Her right DVD increases on left head tilt, and her left DVD increases on right head tilt. Now, in a prospective study, we observed that 57% of patients with DVD behave on head tilt in this classic manner. 19% behaved atypically. In other words, the DVD increased on ipsilateral tilt, and 24% either had no change on head tilt or they increased on both ipsilateral and contralateral head tilt. Interesting. This is a boy demonstrating the atypical pattern. So there's a left DVD, smaller right DVD, and his left DVD increases on left head tilt, and his right on right head tilt. Skew deviation. Skew deviation may have erroneous results on a three-step test, may have a positive head tilt test, and have an erroneous interpretation if you rely on the three-step test. Think of skew when the torsion that you see doesn't fit with the strabismus pattern that you see. And Agnes Wong, of course, has given us the supine head tilt test. With skew, the hyper decreases substantially when measured in the supine condition. This will also be covered in another lecture as part of this series. Myasthenia. Well, myasthenia can mimic any pattern. And of course, that includes superior oblique palsy. Now, you might say technically, if myasthenia causes a superior oblique palsy, it is a superior oblique palsy. But the real diagnosis is myasthenia gravis. And relying on the three-step test is going to give you an erroneous treatment option and clinical course. This is something that's not widely known. There are many patients with horizontal strabismus that have these very small vertical deviations. And if you do a head tilt test and apply the three-step test, you may find that they have a positive Wilczewski, and you may end up getting a three-step diagnosis for a muscle palsy that is not, in fact, the case. This was described by Sally Moore and Ricky Cohen in 1987. So let's look at the top slide of the two slides on your left. This is a patient with esotropia. Now, this is hypothetical. Let's say that there is no palsy of any vertical muscle. When the eye is esotropic, the right eye is esotropic, it is more in the field of action vertically of the superior oblique of the right eye than the superior rectus. So on head tilt to the right, with normal innervation to both of those muscles, you're going to get more vertical vector force from the superior oblique, and there's going to be a relative hypo shift. Whereas if the eye was exotropic, and this is seen in the bottom drawing, it's more in the field of the superior rectus. And on ipsilateral head tilt, you're going to get an increase in the hyper because the superior rectus vertical force vector is going to overpower the superior oblique force vector for depression. It's also known that the three-step test is inaccurate, notoriously, in vertical rectus palsies. Why is that? Well, R. Jampolsky has pointed out that the inferior oblique alone can't elevate the eye above the midline, and the superior oblique alone cannot depress the eye below the midline. And both of those actions would be required by a three-step test with a vertical rectus palsy. This is a video loaned to me by R. Jampolsky, and it depicts the fact that the inferior oblique can't raise the eye above the midline if it's acting alone. This shows someone undergoing strabismus surgery under topical anesthesia. The head is at the top of your screen. Vertical saccades are normal. The superior rectus muscle is disinserted in the usual manner. Testing shows the superior rectus is completely detached from the globe. Afterwards, the eye can make brisk saccades from below to the midline position, but cannot elevate above midline. And that video was loaned to me, compliments of the late and great Art Jampolsky. The three-step test is also inaccurate in the situation of vertical muscle overactions. Again, because the three-step test assumes that we're dealing with a palsy. Let's look at this girl. What you're going to see is an overacting left superior rectus muscle. She developed the typical contracture and swelling of the muscle after a Marcaine injection around the eye. It was confirmed by imaging, and she has an overacting left superior rectus muscle. We're going to move on a little bit to just terminology and diagnosis. Take a look at this picture. Is this an overacting right inferior oblique? Well, the term overacting inferior oblique implies an etiology. And in fact, there are many situations that can cause this pattern that we're looking at, this appearance. And a preferred term would be over elevation in this case, or over depression in adduction, rather than saying the oblique muscle is overacting. Let's take a look at a few examples. Over elevation in adduction. This girl was asymptomatic but found on routine exam to have this impressive motility disorder. There is a Y pattern with marked splaying out of each eye with elevation in adduction. It resembles inferior oblique overaction. However, despite this significant apparent inferior oblique overaction, there is no superior oblique underaction, no elevation on direct horizontal side gaze, and no fundus torsion. This is pseudo-inferior oblique overaction. This condition is probably caused by an aberrant innervation to the muscles. It perhaps can also be caused by pulley heterotopia. This movie that you just saw is the index case of this entity. I first diagnosed her when she was 6 years old. I actually saw her just a few weeks ago. She works in my hospital. She is now 38 years old, has never decompensated her motility. She has never needed anything done for it. It's quite stable. The important take-home point in this is that even though this strongly looks like inferior oblique overaction, weakening the inferior oblique muscles does absolutely nothing to address this pattern. The anti-elevation syndrome. This is the index case of that condition. When viewed on elevation and side gaze, this girl appears to have inferior oblique overaction. In fact, she has bilateral anti-elevation syndrome. As an infant, she underwent bilateral inferior oblique anterior transposition, placing them anterior to the inferior rectus insertion. What looks like inferior oblique overaction is over-elevation due to fixation duress. The abducting eye is restricted to elevation in abduction. This drawing, which is courtesy of Dave Staker Sr., depicts what happens with the inferior oblique to cause anti-elevation syndrome. This is a drawing of an inferior oblique that has undergone anterior transposition, placing it anterior to the insertion of the inferior rectus, which I would say is a caveat you should not do. And if you look at the inflection point in the inferior oblique, you see the neurovascular bundle attach. That actually acts as the functional insertion point for the muscle. And you can see that if the eye is slightly in abduction, then that transposed inferior oblique will be a complete depressor. Or since it innervates on attempted elevation, I prefer the term an anti-elevator. The anti-elevation syndrome occurs probably most often when the inferior oblique muscle is placed anterior to the inferior rectus insertion, but it's also thought to be a function of spreading out the posterior temporal corner of the inferior oblique muscle. It's been said for a long time that one should just bunch the muscle up, almost insert it at a point. I shifted some years ago to doing the procedure as depicted in this drawing. I tack the anterior nasal corner of the inferior oblique just adjacent to the inferior rectus muscle and let the posterior corner just hang back to wherever it wants to go. I have never had a case of anti-elevation syndrome in which I use this technique. Now, unfortunately, there's a trade-off. This is a weaker procedure for DVD. So you have to balance. The more powerful for DVD, the greater the likelihood of getting anti-elevation syndrome. And conversely, the more you avoid anti-elevation syndrome, you're somewhat weakening the effect of the procedure on DVD. Duane's syndrome can have a pattern that may look like an overacting inferior oblique, when in fact it is not. That's part of Duane's syndrome. Let's look at this video.
When viewed in left gaze, this looks like an overacting right inferior oblique. In fact, this girl has Duane's syndrome in her right eye. There is limited abduction of the right eye, and on adduction above the midline, there is an upshoot, and on attempted adduction below the midline, there is a downshoot of the right eye. On adduction, classic globe retraction can be seen.
Pulley issues can cause overelevation or depression in adduction. This is the composite of a teenager who fairly precipitously developed a left hypotropia or right hypertropia, depending which eye he fixed with, in left gaze. The picture shows him fixing with his right eye, but when he fixes with his left eye in left gaze, he has the appearance of an overacting right inferior oblique. This is caused by pulley heterotopia. You can see from the image on the bottom of the screen, bottom right, that his left lateral rectus is infraplaced relative to the normally positioned lateral rectus in the right eye. We talked a little bit about DVD. DVD can mimic an overacting inferior oblique because it tends to often, not always, increase in adduction. They say that that's in part because the nose acts as an occluder. I'm not sure that's the case, the reason, but there are definite differences, and we're going to take a look at them.
This boy has overelevation of either eye on adduction. Cover testing in side gaze does not show a hypotropia of the abducted eye. This overelevation is due to DVD. Contrast that with this boy. He does show DVD in primary gaze. He also shows overelevation of either eye on adduction. However, in this child, cover testing in side gaze shows a hypotropia of the abducted eye. This boy has true inferior oblique overaction coexisting with DVD.
So that's a very important diagnostic point, to tell DVD from just inferior oblique overaction. In side gaze, is there a hypotropia on alternate cover test of the abducting eye? If yes, that speaks to inferior oblique overaction. If no, it speaks to pure DVD. And this is just a picture showing someone who has on the top overelevation and adduction, but when viewed behind the cover, the right eye shows a hypertropia as opposed to a hypotropia. Torsion is something that one must assess as part of the evaluation of vertical strabismus. And I'm just going to talk a little bit about measuring torsion. There is going to be a separate lecture on torsion as part of this series. There are two types, main ways of measuring torsion, two types of torsion, if you will. There's objective torsion, which speaks to an anatomic rotation of the eye as viewed in the fundus. and subjective, which is a matter of assessing what the patient perceives. Now, if you look at the picture on your right, you'll see the fovea is sitting between these two imaginary lines, one level with the bottom of the optic nerve and the other at the junction of the lower third and upper two-thirds, and the fovea is right in between. That means there's normally a range of where the fovea can lie in the normal situation, and it's a range of about 8 or 9 degrees. Objective torsion, which may have no correlation with what the patient perceives, is better at identifying which eye has the problem. These pictures on your right, the top right, shows a marked excyclotropia. The fovea is well below the bottom of the disc, and the bottom picture on your right shows an encyclotropia. The fovea is well above that imaginary line joining the lower third and upper two-thirds of the optic nerve. Subjective torsion is typically assessed with the Maddox rods. Classically, it's the double Maddox rod test and is classically advised using one red and one white Maddox rod. A very nice study by Simmons and Arnaldi and Brown in 1994 demonstrated that you're probably better off using 2 red Maddox rods. There's a tendency for the brain to subjectively normalize the orientation of the line seen by the eye that has a white Maddox rod in front of it. So the double Maddox rod test, particularly if you do it with a white and a red, is less accurate than objective torsion at identifying which eye is torted. But it's the way to determine if symptoms are present that need treatment. And finally, I would say that if you have a double Maddox rod test that shows a bilateral extorsion, the actual result of the test may just tell you the total torsion between the two eyes and be less meaningful for saying how much of it is in one eye versus the other, because of a tendency to normalize the orientation of the line before the dominant eye. If ever you have a patient with unequal vision, always consider the possibility of fixation with the involved eye. This is a right superior oblique palsy in a patient with dense amblyopia in the left eye, and she fixes with the right eye. So we have a left hypo or right hyper, greater and left gaze, and we'll see what it does on head tilt. This has been called the fallen eye syndrome. And you should think of it, as I said, whenever you're dealing with a patient that has unequal vision to the point that they would not be inclined to fixate with one of the two eyes. I have seen this in patients with Duane syndrome, Brown syndrome, thyroid eye disease, and monocular elevation deficiency. So it is something to keep in mind. When we're at surgery and we're dealing with a vertical problem, Dave Guyton's exaggerated force duction tests are essential. Dave generously loaned me this video. It is actually the video that he presented this test to the JAAPOS audience with a number of years ago. And I will say this is also covered in the lecture on reoperations in strabismus, but it's relevant in both places, so I included it here. We're going to be seeing the left eye of a patient seen from above. Horizontal force ductions in the usual manner are normal. To test for torsional restriction, it helps to retropulse the globe, which puts the oblique muscles on stretch. Rotary force ductions can be done in this manner
to look for a torsional restriction. Look for symmetry. To test for oblique muscle tightness, grab the eye at 3 and 9 o'clock. For the superior oblique, push the nasal force up into the superior nasal quadrant and rock the eye temporally in this manner. You can see and feel the eye roll over the superior oblique tendon. For the inferior oblique, do the same in the inferior nasal quadrant. This amount of tightness is normal. We are now going to see a patient with superior oblique overaction and a pattern. When testing for the superior oblique, you can see this marked 3+ restriction as the eye rolls over the tight superior oblique. The inferior oblique is normal. Look at the eye just snap over the superior oblique. Bilateral superior oblique tenotomies were performed and the maneuver repeated. The eye now moves freely when testing for the superior oblique, indicating that the tenotomy was complete.
So this video showed the way Dave Guyton initially described this test. I and others now just use one forcep in the superior or inferior nasal quadrant. I feel that gives me the same information and it's a little gentler on the eye. So we've covered a lot of aspects of diagnosis. I'm going to talk about vertical strabismus treatment. I want to go in depth into superior oblique palsy treatment and some general principles for other types of vertical conditions. So when I pick a surgical plan, my first thought is I need to fix primary position and secondarily down gaze because that's the reading position. You want to pick muscles where what you do to them, recess them or tighten them, will match the pattern. So you get the most correction in the field of gaze at which you need it the most. You should consider torsion in your surgical plan. And I would also add, you can often weaken yoke muscles unless the paretic muscle is really paretic, -3 to -4. If it's -4, weakening a yoke will probably not give you a lot of benefit. And as I outline my approach to fourth nerve palsy, I want to add this aphorism. There are many paths that lead to orthophoria. This is just the approach that has worked best for me. There are many schemas out there in the literature. I like this, which is, of course, why I use it. And hopefully you'll find this valuable and simple. So when and these grids I'm going to show you are all on all depicting a hypothetical right fourth nerve palsy. So the first question I ask myself is, am I dealing with what should be a one muscle or two muscle procedure? It's rare for one to need three muscles in the initial approach. And what determines that for me is the size of the deviation in primary, because above all, I do not want to overcorrect a fourth nerve palsy patient in primary because they'll be diplopic and they'll be unhappy. And my cutoff is at about 15 prism diopters. If the deviation is under 15 prism diopters in primary, irrespective of the side gaze, in primary, it's a one muscle procedure for me. If it's 15 or more, I'm probably going to do a two muscle procedure. Now, the only caveat is if this is a patient, given age and cooperation, I can do adjustable sutures on, I may have that cutoff move down to about 12 prism diopters, particularly if the side gaze deviation is very big. So let's say we're dealing with one muscle case, under 15 in primary, and the 3 pluses up and right show that the deviate up and to the patient's left, your right, show that the deviation is greatest up in the field of the right inferior oblique. And I think most people will weaken the inferior oblique in that case. Now, the next pattern is if we have 15 in primary, less than 15 in primary, and big deviation all across the adducted field. I'll still just weaken the inferior oblique. It's a one muscle procedure. What about this pattern where the deviation is greatest down in the field of the superior oblique? This is a classic pattern for doing a superior oblique tuck. And I think that tucking the right superior oblique is a very appropriate thing to do in this situation. However, I recognize that there are many people who don't do very much superior oblique surgery and aren't comfortable doing the superior oblique. And I would say in almost all cases, you can avoid doing a superior oblique tuck by, in this pattern, recessing the contralateral inferior rectus muscle, the left inferior rectus. That'll help the hyper, but it won't really address the torsion. So you can simultaneously nasally transpose the right inferior rectus, about 7 millimeters is what I do, to address the torsion. And that works very well in these patients. Now, the next thing I want to say may be a form of heresy, and I expect a lightning bolt to hit me whenever I say this, but tendon laxity does not play any role in my decision whether or not to tuck the superior oblique. In my mind, saying that you have to tuck a lax superior oblique and you shouldn't tuck a non-lax or tight superior oblique is kind of like saying if you have a lateral rectus paralysis, you need to resect or plicate a flaccid lateral rectus muscle, and if it's got some tonicity to it, you have to avoid resecting it, when in fact the exact opposite is the case. Tendon laxity, and I test for it, tendon laxity informs my decision how much to tuck if I've decided I'm going to tuck. Lax tendon, a bigger tuck. Tight tendon, a smaller tuck. But it does not inform the decision whether or not to tuck. So now we're talking about a situation where the deviation in primary is greater than 15 prism diopters. That's my two muscle situation. And back to this first scenario I showed, the deviation is greatest up in the field of the inferior oblique. I will weaken the inferior oblique muscle and recess the contralateral inferior rectus muscle, and if appropriate, using an adjustable suture. If the deviation is big all down the adducted field, up, horizontal, and down gaze, I'll do the same thing. Weaken the inferior oblique and the contralateral inferior rectus muscle. And this pattern where the deviation is big all across the bottom and up and down in the adducted field, again, the same procedure. Right inferior oblique, left inferior rectus recession, adjustable if possible. Now, there's one caveat to this relatively simple approach and schema, and that is if I have more than 10 of hyper in the horizontal abducted field, in other words, it's greater than 15 in primary, and in horizontal right gaze, it's greater than 10. That's strong evidence that we're dealing with right superior rectus contracture or right superior rectus overaction. Sometimes it takes the form of an overacting muscle rather than a contractured muscle, in which case you don't really feel it on forced ductions. I'll do the inferior oblique in a very small superior rectus recession ipsilaterally. If you do generous surgery in this setting, if you weaken both elevators and you do a standard size recession on the superior rectus, you're really going to cripple up gaze. So this is a situation I find myself doing 2 millimeters, 2.5 millimeters on the superior rectus muscle. As I said earlier, there's obviously some overlap between these topics in this lecture course. DVD, the evaluation and treatment, will be covered separately, as will thyroid eye disease. And I'm not going to go into thyroid eye disease in any extent in this lecture. So we've talked about a comprehensive approach to vertical strabismus. We talked about diagnosis, how the history can help, determining if we're dealing with DVD. Got to see the DVD lecture to learn how to handle it. Fixation with the involved eye. Think of it when there's unequal vision. The pattern helps with the diagnosis. And of course, errors in the 3-step test. Treatment approach, choose muscles to match the pattern of the deviation. You need to release restrictions. You can weaken yoke muscles, and you need to consider torsion. Couple of soft signs. If the incomitance pattern is larger vertically, in other words, there's a bigger change in the deviation from down to up than there is from right to left, think of a vertical rectus problem or a vertical restriction. Whereas if the horizontal incomitance is larger horizontally, bigger deviation, left gaze to right gaze, than up to down, think of an oblique problem. If the forced head tilt difference is very large, think of an oblique problem or maybe DVD. If it's small, think of a rectus muscle problem or most other causes. Now, none of these soft signs are absolute. That's why I call them soft signs, but they'll help steer you in the right direction. This is a set of photographs of a child with the largest head tilt that I've ever seen due to a vertical rectus, in this case, superior oblique palsy. You see on the left picture, she's in casual gaze, and with visual effort, she almost turned her head horizontally. Never seen one bigger than that. I want to thank you. And as I often say, my wish for you is that all the roads you travel lead to orthophoria. Well, I want to thank you again for your attention. I hope you found this useful on understanding the evaluation and treatment of vertical strabismus. If you did find it useful, I hope you tune in to all of the other lectures in this series, the comprehensive course on strabismus, sponsored by One World, One Vision.
In bringing you this video course, there are many thank yous. Thank you for viewing the video course on strabismus. We hope you found it stimulating and educational, and that you share its insight with others. We at One World, One Vision extend our heartfelt thanks to the lecturers who shared their years of study to make the video course worthwhile. And of course, to Burton Kushner for taking on the burden, happily we hope, of development and moderating. We also thank the Board of Directors for their continued guidance. We thank our donors for their financial support that made this video course possible. An enormous thank you to the video team of Sweet Sadie for their extraordinary efforts to make the course, both visually and auditorially, extraordinary, and for their technical guidance of lecturers. Thank you, Rachel, Tim, Eddie, and Bill. If you are interested in learning more about what we do, go to our website, www.oneworldonevision.org. And finally, if you have comments or thoughts or ideas, you can email me at owov2020@gmail.com. Goodbye.